They also don't assess the bleed. I don't assess whether they assess the bleed. Like they jump immediately and they shoot the person. See, that's what we're doing. Do they do the person? Actually, the better place it. You better than right down low. And I'm probably a little biased because I was on this company where there were people who would say, you know, everybody. So I had two, yeah, and I what so I actually think the
Hello, everyone. I think we're going to get started momentarily, so get everybody in here and please take your seats. And our first speaker, please come up to the podium.
Yes, our first speaker is Jacob Hammond from Mayo Clinic, Arizona. The title of his talk is The Influence of the Operating Room Temperature and Humidity on Surgical Site Infections, a multi-site ACS NISQIP analysis. And this is a Jack Barney finalist.
Good morning, everybody. Thank you very much for the opportunity to present our research here today. Here we're looking at the influence of OR temperature and humidity on surgical site infection. We have no disclosures. So imagine you're at your hospital, it's 7 a.m. Your combined colorectal, vascular, orthopedic, and plastic surgery case you've been working on months to coordinate is about to roll into OR 20. But then you get a page from the OR manager. The relative humidity is 19%. It's a range outside of our recommended ranges. Would you like to proceed? And this page is what spawned this study. The recommendations by the American Society of Heating, Refrigeration, and Air Conditioning Engineers recommend that OR temperature be kept between 68 and 75 degrees Fahrenheit and a relative humidity of 20 to 60%. These are the recommendations enforced by the Centers of Medicare and Medicaid Services, CMS, and the Joint Commission. The thought behind those parameters is that those may have an effect on surgical site infection, which surgical site infection does lead to increased patient length of stay, morbidity, as well as higher healthcare costs. Data evaluating the influence of ambient OR temperature and humidity is significantly lacking. So our main research question that we sought to answer with this study is, what is the relationship between OR temperature and humidity and surgical site infection? So to answer that, we conducted a 3-site ACS NSQIP case data review from 2016 to 2020 amongst all surgical specialties, anywhere, all cases from general surgery all the way to neurosurgery, orthopedics, and plastic surgery. Our primary endpoint was superficial SSI. And we looked at superficial SSI because the superficial aspect of the wound is the part of the wound most exposed to the ambient OR environment. And outcomes such as deep or organ space SSI are a lot more associated with host factors as well as aspects of the operation itself. And then we looked at the median OR temperature and relative humidity. Now to get these data, we use software called TempTrack, which is a 24/7 wireless environmental monitoring system that pings the OR and takes temperature and humidity data recorded in continual 15-minute intervals. We then took the environmental data, the temperature and humidity, and put it into 3 categories: low, less than 10th percentile in terms of all total readings; medium, 10th to 90th percentile; and high, greater than 90th percentile in terms of a temperature or humidity reading. We then performed a multi-level logistic regression, taking into account patient factors, case characteristics, including OR length, an interaction term between the surgical specialty and the particular OR that a case was conducted in. And then we looked at the effect of that model on intraoperative temperature and humidity. Our independent variables included the patient factors, which are the main factors included in ACS NSQIP, including ASA, age, diabetes, cancer, et cetera. The next level included the looking at surgical specialty and operating room interaction term as a second level random effect. And then for the third level of the model, we looked at the year of the operation. And then generating this model ended up creating a C statistic of 0.827. And then we looked at this model and then evaluated the effect, the observation specific estimate of SSI risk as a covariate to evaluate the influence of temperature and relative humidity on surgical site infection. We then looked at another regression analysis looking at the combined impact of temperature and humidity on superficial SSI. So in order to get our data, we looked at all 3 of our Mayo Clinic sites. We excluded cases of open wounds, deeper incisional SSIs, organ space SSIs, cases including a preoperative diagnosis of an SSI, as well as procedures in which no surgical wound is created, such as a cystoscopy. We then excluded cases without any environmental data available. And then we excluded cases missing any NSQIP variables or any evidence of surgical duration in the data set. We ended up with a total of 14,519 cases. And of those total cases, we had a low rate of superficial SSIs, about 1.2%, or a total of 179. Overall, the median OR temperature and humidity were 68.2 degrees Fahrenheit and 43%. These were our cutoffs for our 3 groups of analysis. So a less than 10th percentile cutoff for ambient OR temperature humidity was 64.4 degrees and 33.5% relative humidity, whereas high was what seems to be like a comfortable temperature, greater than 71.3 degrees Fahrenheit and greater than 55% humidity. In looking at the effect of low and high temperature in and of itself, we found no significant risk of surgical site infection for both low temperature as well as high temperature. So both of the extremes on the percentiles. And looking at just humidity of itself, comparing low and high humidity versus the middle, we also found no significant risk of superficial surgical site infection for both low humidity as well as high humidity. Now, this is a very busy slide, but in summary, it's comparing the combined effect of a low temperature, low humidity versus the middle of the groups. And I'll just draw your attention to this slide here. No real significant differences, but low temperature, high humidity was associated with a decreased risk of SSI. So overall, our findings are showing no significant increased risk of SSI. Limitations to our study include a low rate of SSI, 1.2% of the entire group for analysis, which led us to not be able to test the actual ranges that are recommended. And then a lot of studies looking at this factor looks at air quality data, which we weren't able to obtain in a retrospective fashion. So in summary, significant deviations in ambient OR temperature and humidity do not increase the risk of superficial SSI. With that, I'm happy to take questions. Thank you.
Stephanie Namir from Texas Tech will be the invited discussant.
Hi, thank you so much, Dr. Hammond, for a really interesting and excellent study looking at how some of the factors in our operating room in terms of temperature and humidity can affect superficial surgical site infection risk. I thought that this was really interesting. One, because I didn't realize that they had that kind of data for our operating rooms in 15-minute increments. And so that's really neat that one, that you were able to identify that exists, and then able to use that combined with the other data that you had from your institution to really look at whether that is independently affecting your surgical site infection risk. I did wonder if you could comment on your choice of the median as your measure, as opposed to something like an average. Obviously, those are giving you slightly different information. I also did note that the vast majority, if not all of your humidities were within the range that is recommended. And so I wondered whether you could comment kind of on that. You did not in this study look at patient temperature, and we know that core body temperature has been shown previously to impact rates of surgical site infections. And I did note the one group that you had, which seemed to have a different, statistically significant difference in surgical site infections, was in your low room temperature group, low room temperature and high humidity. And I wondered whether truly that's a marker for a warm patient more than anything, which could be the reason why you see lower in that particular group. And I just wanted to, again, congratulate you on a really excellent study. It's nice to know what we don't have to concentrate on so that we can spend a little more time concentrating on the things that are important for giving our patients good outcomes. Thank you.
All excellent questions. Looking at median versus average, we talked about it quite a bit, and we really wanted the temperature and humidity ranges that we were looking at for each operation to reflect essentially most of the operation, and not instances where, let's say, the sensor didn't pick up the temperature right, or it picked it up as a very low, false low reading. And we didn't want those outliers to really impact the entire average of the operation. So we ended up just going with the median just because it was a more consistent number, free of effect from outliers that could be false readings or readings that we don't really want to look at. Very astute observation that we didn't get a chance to look at cases outside the ranges that are recommended. The reason was because we really had a very low number of SSIs to look at. You know, I think if in looking at our data set, the number of actual observed SSIs that happened below the temperature range was maybe 11 or 12 total cases. So with that, we had to really look at it more as a categorical variable of outliers, because we didn't have enough cases to look at instances outside the actual recommended ranges. And going back to your last question about the effect of the patient, I think that there's already a lot of good literature out there that show that the temperature of the patient actually has a profound impact on their outcome. The purpose of our study was not to really reinforce that, since we think that that's out there, but was to determine is the ambient OR temperature in and of itself a quality metric that hospitals and institutions should focus a lot of their efforts on in order to decrease the impact of SSIs on their institution? And I think that we were able to answer that to a sense. But overall, very good questions. Thank you.
Jacob, that was really well presented. So my question actually was in regards to having not that many outcomes and using the 10th percentiles. If you guys would have used different percentiles, in theory, you'd have more power. Do you think that would have changed your analysis? And have you guys thought about doing sort of analysis to look for an inflection point where you might have lower rates or higher rates of infection?
I think it's a good question. I think we had chose 90th and 10th just because that would give us a good, that's a good, it's a good cutoff just because it shows that those are actually indeed extreme deviations that would happen and it would be relatable to people reading the paper. But I think it is a good point that if we were to change our ranges, it would affect, the number of cases that we could get and those overall outcomes. But I think we had just chosen those and talking with our statistician and overall like the ability of the impact of what the paper would be. We really wanted to look at the most extreme deviations we could find just to kind of really answer that question, since we couldn't really look at the actual ranges or outside the ranges. We wanted to get a good cutoff for what we would call a very high deviation as opposed to less deviations, if that makes sense.
Any questions from the audience? Come up to the microphones. As people are coming up, I may have one question for you. Have you thought of enriching your data with just those cases that are high risk for infection? Because, taking all comers, there are a lot of cases in there have a very low risk of infection anyway. So hard to move, they're about 1% or low anyway. Just looking at cases that are high risk for infection and see if that changes.
Yeah, we could. We already have the NSQIP kind of outcomes, which take into account ASA, disseminated cancer. We also took into account emergency surgery, surgical subspecialty. So I think it might be worth looking at that whenever we look back at our data. Thank you.
Okay, thank you.
Thanks, everybody.
Our next speaker is Dr. Shivani Desai. He's going to talk about the impact of methocarbamol on opioid use after ventral incisional hernia repair. And he comes from the University of South Carolina. Oh, sorry, she.
Good morning. My name is Shivani Desai. I'm a PGY1 general surgery resident at the University of South Carolina and Prisma Health Upstate in Greenville, South Carolina. I'd like to first thank the program committee at Southwestern Surgical for the opportunity for the podium this morning. Today, I'll be presenting our research on the impact of methocarbamol and opioid use after ventral incisional hernia repair. I have no conflicts of interest to disclose. What I'll be reviewing over the next several minutes of our presentation is the current treatment for postoperative pain, as well as the emergence of multimodal analgesia, our study on the impact of methocarbamol and opioid use in the postoperative period. And finally, what does this mean for our pain control in our postoperative patients and how it can impact our practice moving forward. Starting off with current treatments for postoperative pain, I feel that this presentation would not be complete without discussing how we got here. The patent on OxyContin or oxycodone in the 1990s changed the way that we prescribe medications for our patients in the postoperative period. There were some studies early on published about the use of oxycodone in our surgical patients that highlight its abuse potential. However, they're described as a very low abuse potential if used properly. This impression, combined with the push for optimizing patient satisfaction through what we know as the fifth vital sign, led to an exponential growth in prescribing. If we fast forward to 2006, we see that the result of liberal prescribing of narcotics contributed to what we now know as the opioid epidemic. In 2006, we saw as many as 215 million narcotics prescriptions nationwide. And although we have efforts now to decrease that, in 2020, the CDC reported now 142 million prescriptions of narcotic. This makes our prescribing more important than ever, and drives our goals to really find non-narcotic alternatives for pain control. Current treatments for postoperative pain are variable across institutions. A variety of factors affect prescribing, including the type of operation, the surgical approach, and of course, surgeon preference on prescribing. The emergence of multimodal analgesia, which typically includes the use of non-narcotic medications such as acetaminophen and NSAID, gabapentin, and muscle relaxers, has demonstrated the importance of developing new protocols for postoperative pain. At our institution, we have previously conducted studies on opioid use and other alternatives postoperatively. We began by using ketamine infusions intra and postoperatively in our patients, and we almost completely eliminated the use of patient-controlled analgesia with this method. We then evaluated the use of tap blocks and have demonstrated decreases in opioid use as well as hospital length of stay. Evaluation of patient-reported opioid consumption also revealed at our institution that over half of patients undergoing inguinal and primary ventral hernia repairs do not require any opioids postoperatively. As such, we've developed our own multimodal regimen to use in our institution, as highlighted here, including the use of an acetaminophen, an NSAID, and methocarbamol or Robaxin, with opioids available for breakthrough pain. The subject of this presentation, though, is methocarbamol, also known by the trade name Robaxin, which is a centrally acting skeletal muscle relaxant. We don't really quite understand its mechanism of action, but we do know three things: that it's a non-narcotic, it has a low side effect profile when compared with opioids, and it's affordable for our patients. Side effects include nausea, vomiting, drowsiness, or dizziness. And according to GoodRx, a prescription is quite affordable for patients. A 30-day supply of 500 milligram tablets costs between $8 and $13. While proven to be effective in studies on rib fracture, spinal surgery, and breast augmentation, there's still a gap in research of methocarbamol and the use in general surgery cases, as well as hernia repair in specific. The goal of our study is to determine the effect of methocarbamol to a postoperative analgesic regimen for open and robotic ventral incisional hernia repairs. We conducted a retrospective review from January of 2020 to July of 2022 with 101 patients included in our study group. We used a 2-to-1 propensity matching to limit our confounding factors in the selection bias that can occur with observational data. Patients were matched according to gender, BMI, surgical approach, wound classification, and width of defect, with our primary endpoints being total morphine milligram equivalents prescribed, need for opioid refill, and need for rescue opioid. Our groups were pretty well matched with no significant differences in demographics or major comorbidities. I'd like to call attention to two specific categories: our surgical approach as well as our hernia width. Our surgical approach between robotic and open was pretty evenly distributed, as well as our hernia width. You see approximately 20% had defects larger than 11 centimeters. So we have included some pretty large defects in this study. We found no differences in total inpatient MME between groups. However, patients receiving methocarbamol were prescribed a significantly less opioid at time of discharge, a median of 60 versus 75 MME. And despite lower MME prescribed, there is no difference in needs for opioid refills. We did have 2 patients in the methocarbamol group that were initially prescribed no opioid that later required a rescue prescription. Things to consider in regards to this study that may contribute to our findings. Patient outcomes are not reported here, which does not allow us to fully assess the efficacy or adherence to our prescribing protocols. Prescribing less does not necessarily equate to improved patient quality of life, as we well know. Our operative approach is another consideration here. Although the distribution of open versus robotic repairs is pretty evenly similar, we didn't perform any subgroup analysis between the two. Similarly, we did not perform a subgroup analysis by hernia size, which is another thing to consider when influencing postoperative pain. Finally, what does this mean for our patients and how can it affect our practice? While methocarbamol may not replace opioids in patients undergoing incisional hernia repair, it can be a useful adjunct in our patients. Intuitively, the use of a muscle relaxer in patients that undergo extensive myofascial release and manipulation of the linea alba, it makes sense, and it's something that we should consider. It's worth to consider in your practice to mitigate a patient's pain, especially with the minimal side effect profile. This study is retrospective and outcomes may be influenced by selection bias. We're currently conducting a prospective pilot study to the use of methocarbamol in inguinal and ventral hernia repairs. And the enrollment is currently ongoing to study this further. I'd like to thank the people mentioned on this slide without whom this presentation would not have been possible. Thank you so much for your time, and I'll now open the floor to questions.
Thank you. Thank you. That was excellent. And I forgot to mention, this is also a Jack Barney Award finalist and also a Laurie Award finalist. So our discussant will be Dr. Eric Campion from Denver Health Medical Center.
Thank you. So very, very well presented. Great job, especially as a first year, really good presentation skills and a really excellent study. So I applaud Dr. Desai and her other authors on really kind of tackling a very important topic during the current opioid crisis here in the United States. I think, this is something that we want to continue to look at and continue to find ways to drive down our narcotic use. So fantastic work. I do have a few questions, and I think a lot of these are really just probably related to the limitations of the data set that you're using. So were patients selected in this study for matching during the same time period of those 2 years, or were they skewed, let's say, the control group to the early part and the Robaxin group to the later part, which may affect, they may see a difference of prescribing practices over time rather than directly related to the Robaxin? Second question is, do we have any pain scores for these patients? A lot of the nursing charting kind of religiously documents pain scores. And if so, were there any differences between the groups in those pain scores? For the discharge opioid prescriptions, I noticed that you described that you use the 24-hour MME to help guide your discharge prescriptions, but given that there wasn't a significant difference between the groups on the inpatient side, is there an explanation as to why we necessarily gave less discharge in those patients? And could this just be that the providers are assuming the patients are going to need less when they get the Robaxin as opposed to when they do not? And obviously, we don't have data as to how many pills the patients took in your study. And so therefore, we really don't know if decreased prescribing was actually anything reflective of decreased need. And then last, did the patients in these groups have any concomitant blocks, epidurals, or other regional pain control? And if so, were there any differences between the groups? So I applaud you guys. Great study, and keep up the work.
Thank you so much for all of your questions. So to address your first question about the matching, our patients in the matched groups were from that same time period as the study group. And then could the differences in the outpatient prescriptions be due to changing practices? We instituted the standardized prescribing protocol at our institution back in 2015. So these have been in place for quite some time. Robaxin was added in 2020, which is about the time during this study period. So, we don't have data on the compliance with the prescribing protocols amongst, residents and attending physicians. So there is, it's possible that some of the bias exists there. However, because these have been in place for such a long time, there's certainly a decreased chance of that occurring. As far as pain scores are concerned for these patients, we didn't have any pain scores included in this study, which is certainly a limitation. We've used them in prior studies and found them to be a little bit unreliable because they're difficult to track in our EHR system. And so, that's why we're having this pilot study now that's being conducted, which will include patient quality of life scoring to hopefully give us a more better idea of how methocarbamol can impact this. For the discharge opioid prescriptions, for any protocols, again, we use the 24-hour MME use. It can be kind of tricky with patients that have, a 24-hour, like a shorter length of stay in the hospital. So, there is probably some variation there. However, you can see clearly in our data, we only had 2 patients that underwent hernia repair that needed a rescue opioid prescription that were not initially prescribed an opioid. So I think that speaks to the impact of this study with that, there's a chance that maybe some folks are prescribing less with this idea in mind. However, the data seems to support it and it seems to work. And then I think for your last question, for the concomitant blocks or regional blocks, TAP block at our institution is standard for all of our ventral hernia patients. So that answers that question. Thank you so much.
All right, we have some questions from the audience. We'll start with to my right.
Okay, Krista Couch, Fresno, California. We've gone to the use of muscle relaxants fairly extensively, but there's a couple of populations where you're concerned about muscle relaxant use in the geriatric population. And you also want to think about the patients who have renal impairment, chronic kidney disease. Were any adjustments made to reflect patients who are older, more mature, I'm sorry, and who had any degree of renal impairment?
So we did not adjust for those to my knowledge. It's certainly an area to explore more because especially with opioid use as well, we worry about our geriatric population. The nice thing about Robaxin or methocarbamol is that the side effect profile is more minimal and it has less severe side effects than what we know from opioid medications. I think it's an area that we can explore as we look into our pilot study a little bit further, where we can maybe stratify some of these outcomes. Thank you.
Hi, Jacob Hammond, Mayo Clinic, Arizona. Excellent talk. Just a couple of questions. For TAP blocks, any use of liposomal bupivacaine or Exparel? And the other one is just kind of a technical question. Congrats on moving this study to a prospective fashion for subsequent stuff. But why 500 milligrams? To me, that seems like a low dose. Sorry, why 500 milligrams for Robaxin?
Yeah, that's a great question. So 500 milligrams is the lowest dose it's a starting dose for Robaxin. And so that's where we started. There's no additional thought process behind that, but it's something, people have different tolerance to medications or may require more. It's certainly an area, but we needed a good starting point and the lowest dose is good there. And then as far as the liposomal
Yep. Our next talk will be by Hadley Wilson from the Carolina Medical Center, entitled "An Analysis of Quality of Life Outcomes in Recurrent versus Primary Ventral Hernia Repair" from the International Hernia Mesh Registry. And this is also a Jack Barney finalist.
Can you hear me now? Yeah. Okay. Thanks for the introduction. I am presenting a prospective international analysis of quality of life outcomes in recurrent versus primary ventral hernia repairs. Here are our disclosures. So traditionally, successful ventral hernia repair has been defined as one having no recurrence. But advancements over the past 20 to 30 years, such as increased emphasis on prehabilitation, use of prosthetic mesh, and advancements in techniques have made much more ventral hernia repairs technical victories, with recurrence rates significantly reduced. More emphasis is now being placed on other metrics of success in ventral hernia repair, such as quality of life now. Quality of life is a key outcome measure in this surgery and is perhaps the single most important reason patients seek an elective surgery. Indeed, many hernia surgeons now consider themselves quality of life surgeons. We've seen improvements in the literature of quality of life in ventral hernia repair for a variety of defect sizes, age groups, and operative techniques, but the effect of recurrent ventral hernia and its effect on quality of life outcomes after a subsequent repair are still poorly understood. There have been studies suggesting that recurrent ventral hernia repair is a risk factor for lower postoperative quality of life, but these have not taken into account preoperative quality of life, and no study has directly compared recurrent versus primary ventral hernia repairs. So the goal of this study was to compare these two groups and their quality of life outcomes. We use the International Hernia Mesh Registry, or IHMR, which is a prospective international hernia-specific database, collecting data from numerous institutions throughout North America, Europe, Australia, and South Africa. It reports quality of life outcomes with the Carolinas Comfort Scale, which is a hernia-specific quality of life metric developed at Carolinas Medical Center. The Carolinas Comfort Scale, or CCS, looks at three main symptoms: pain, activity or movement limitation, and mesh sensation, and asks about these symptoms in 8 different common activities on a 6-point Likert scale, ranging from 0 for no symptoms to 5 for disabling symptoms. We have published several studies using the CCS, reporting on large cohorts and quality of life outcomes in other comparisons of ventral hernia repair, as well as inguinal hernia repair in the past. We identified about 1,350 patients with 1,122 primary ventral hernia repairs and 227 recurrent ventral hernia repairs. Overall, these groups are pretty similar, but recurrent ventral hernia repairs are more often female. Both groups were on average obese, but recurrent patients had a slightly higher BMI on average. And recurrent patients were also more often taking pain medication specifically for their hernia. Operatively, recurrent ventral hernia repairs had larger defect sizes, about 80 square centimeters versus 40. And they also more often required component separation almost a quarter of the time. Complication rates such as recurrence and wound infection were overall similar between these groups. These are kind of the meat of our outcomes. So we compared the average sum scores from each of these symptom categories preoperatively and at 1 year post-op. So these are the graphs for the outcomes for pain and movement limitation from the CCS. And the blue bars are the preoperative scores, and the orange bars are the postoperative scores at 1 year. So you can see in recurrent patients, they had higher preoperative symptom scores and higher postoperative symptom scores. But importantly, both groups improved in their quality of life with a reduction in these symptoms. And interestingly, recurrent ventral hernia repairs had a greater magnitude of improvement in these symptoms. They did, however, have slightly increased mesh sensation postoperatively compared to the primary patients. We didn't look at the difference of this, as we presumed primary patients wouldn't have mesh sensation preoperatively. We performed a multiple linear regression to examine the independent effects of variables on these quality of life symptoms. And we saw that recurrent ventral hernia repair was independently predictive of increased postoperative mesh sensation and was predictive of a greater improvement in movement limitation. Interestingly, an unanticipated finding from this study was that the variable most closely associated with affecting all of these symptoms was taking pain medication for the hernia preoperatively, which was a risk factor for increased mesh sensation and was predictive of significant improvements in pain and movement limitation. Conversely, we did show that preoperative pain score in total was predictive of having symptomatic pain symptoms or a score of 2 or greater on the CCS in any item after 1 year. In conclusion, this study improves our understanding of quality of life outcomes for recurrent ventral hernia repairs. This can help set patient expectations and help with shared decision-making in the preoperative clinic. We saw that recurrent ventral hernia repairs had worse preoperative and worse postoperative quality of life compared to the primary patients. But importantly, these patients still benefited substantially from a revisional repair. They can be warned that they may have some increased mesh sensation compared to their first repair. And finally, patients taking pain medication for their hernia preoperatively, interestingly, seem to have the greatest benefit in quality of life symptoms. Thank you for the opportunity to present, and I'm happy to take questions now.
This paper will be discussed by Mark Savaras from the University of Utah.
Thanks. Am I on? Yeah. Thank you. I'd like to commend the authors for this excellent study, and also just generally acknowledge the debt that we owe to the Carolinas group for advancing our knowledge on hernia repair outcomes. I'd also like to praise you guys for using this database, the International Hernia Mesh Registry, to actually address a clinically relevant issue. I don't know how many of you in the room get requests to review journal articles, but a lot of times in recent years as a reviewer, I've been asked to evaluate manuscripts where it seems the authors have just taken a bunch of data from a registry and come up with some statistically significant finding that really doesn't mean anything clinically. And I think what you guys did is the opposite, where you wanted to know if patients who had to undergo a redo or repair of a recurrent ventral hernia actually did worse than the patients undergoing their first repair, because it seemed like the literature and conventional wisdom said that that was the case. I'm going to make the assumption that at Carolinas, you see a lot of patients with complicated and recurrent ventral hernias, and you had an idea that your own outcomes didn't jive with this thinking. So the problems, as you pointed out with the previous studies, is that none of them really took into account the baseline for quality of life from which the patients approached their operation. They all looked at the outcomes and the quality of life afterwards. And just like you found that the patients who had a recurrent repair had a slightly lower score, but it didn't take into account the improvement from the baseline scores that you showed. In fact, when you look at the two of the three measures in yours, pain and movement limitation, it seems like it was about twice as good for the patients undergoing the recurrent repair. This, I think, is really important information to the practicing surgeon, because when you see these patients, you can't control what they've had done. You can only control what you can do for them. And so knowing that you can help these patients, I think, is useful. You pointed out a couple of other interesting things that I want to emphasize to the audience first of all, the complication rate from ventral hernia repair is extremely low. If you exclude seroma, which I'm not sure is really a complication, you guys had a cumulative complication rate, which was hematoma, wound infection, DVT, pneumonia, and ileus, was between 3.5% and 5%. There were no fistulas, there were no cardiac complications in these 1,400 patients. The recurrent hernia recurrence rate, as you pointed out, was extremely low. And so we've sort of gone past those things. So the quality of life is really, truly the outcome for these ventral hernia repairs. The second thing, as you pointed out, is that the patients who started off the worst had the best improvement, not just in the recurrent hernias, but also the patients who are taking pain medication and the patients with a high BMI. Those patients had the best overall improvement in quality of life. So again, I want to congratulate you guys on this study and the conclusions that you came up with. So I'll give you two questions. First of all, can you provide us all some detail about this mesh sensation as a quality of life measure on the hernia registry? It doesn't sound that severe. The others are limitation on activity and pain, and then there's this mesh sensation. And just discuss that a little bit. And then secondly, the hernia registry is open to everybody and it's voluntary, but really it's mostly used by people who are experts or aficionados in hernia repair. So is there a bit of selection bias using this registry data that suggests that it can't be extrapolated to the average surgeon who's doing hernia repairs? And then I guess the follow-up to that would be, does that suggest that the more complicated hernias really should be done by people who have a specific interest in it? Thank you very much.
Thank you, Dr. Savaras, for that excellent summary. And I think you make a lot of excellent points about the state of hernia repair in general and our article. So to address your first question about mesh sensation, I think you're absolutely right. It is kind of a harder symptom to pin down compared to pain and movement limitation. You know, these are patient-reported outcomes, so these are what patients feel. And in the IHMR, they're submitting these quality of life questionnaires online. So, you know, we don't really have confirmation that the sensation they're having is really the mesh. it could just be discomfort. I think the argument against that is that while we see, I think the outcomes from this study sort of make sense in the way that we see pain and movement limitation reduce, but patients with larger hernias and the recurrent hernias that may have now multiple meshes in, we do see have increased mesh sensation. So, that makes me think that there is some truth to this, but again, hard to pin down. But patients have a very odd understanding of mesh due to the press. We've actually looked at this before in our clinics, and patients have done a questionnaire coming in about their thoughts on mesh. And we found that basically 45% of patients coming into our preoperative clinic said, if I'm going to get a mesh in this operation, I'm going to have a complication, and that just mesh equals complications in their mind. So we have to do a significant amount of education in that regard. For your second question, based on the kinds of centers we're seeing in the IHMR and how this can be extrapolated to the general community, I think you're also absolutely right about that. I think there is some bias with these results, and with the data is generally submitted by specialized hernia centers that have a specific interest in hernia repair. And so some of these outcomes can't necessarily be extrapolated to, the general community practice. The problem is, the number commonly quoted is that there are 500,000 ventral hernia repairs done a year in the United States. It's estimated 20% of these are recurrent ventral hernia repairs. So that volume, 100,000, I don't think we can say that every recurrent ventral hernia repair needs to be referred to a specialized center of excellence. The kinds of patients we know from our experience that maybe should be referred are patients with pulmonary comorbidities that have significant loss of domain. We know those patients typically require more ICU level care. And also patients with increased complexities such as a mesh infection that needs to be excised, or EC fistula. And we have some data coming out now that we haven't published yet, but that patients with multiply recurrent hernias or 2 or more recurrences previously maybe should be sent to a referral center as well. Thank you.
Yeah, we have one more question up front.
Sorry, Julianne Beginners, Mayo Rochester. Thank you very much for this beautiful paper, looking at what happens to the patients, what the patients experience. In that, I was wondering, can you tell us about the missingness of data at 1 year? That usually is a big problem with quality of life data after 1 year, that it's usually not 100%, and that may affect your data. Do you know, from what you're saying, you're looking at the recurrent hernias, do you know what the subset of recurrent hernias looked like in your data set? Was there a similar thing? Was it so the 2-time recurrent hernia, is that worse than the 1-time recurrent hernia? And do you think it would help us understand what actually should happen to the patient if we know something about the social functioning, the physical functioning, as it's inhibited by mesh sensation, pain, things like that? I know the CCS does not include that, but some of the other generic QRL instruments do, and that would tell us, can the patient not work, or can they not go out with their friends because they have this?
Yeah. So to address your first question, I'm sorry, remind me of the first question again.
The missingness of the data at 1 year.
Yeah. So we included, when we designed this study, we only included patients that had these quality of life outcomes available.
About typhoids.
Yes. So, but it's an excellent point. And we were missing quite a bit of clinical outcomes from some of these patients. A lot of this quality of life data is collected from the patients down the road, like in an online format. So, and then your second question.
Regarding the data on recurrent hernias, if they're different.
Yeah, so the patients had an average, the recurrent patients had an average of about 1.5 previous hernia repairs. So we were seeing a good amount of recurrent hernias there. The data is pretty lacking on recurrent ventral hernia repair in general. So we did not do a subgroup analysis of the recurrent hernias, but definitely something worth looking at in the future.
All right, thank you.
Is there any more time?
No, check them later. All right. Our next speaker is Sarah Davis from the University of South Carolina School of Medicine. She'll speak on rectus to defect ratio for estimating the complexity of ventral hernia repair. Is it reliable for robotic surgery?
Great. Hi, my name is Sarah Davis, and I am a second-year medical student at University of South Carolina School of Medicine, Greenville. And I'm going to tell you about my work with Dr. Love on the RDR tool for hernia repair. So to give you some background, the common approach to midline ventral hernia repairs is the Reeves-Stopa technique, which involves bilateral rectus myofascial release and placement of a retromuscular mesh. If the defect cannot be repaired with this approach, then additional release is necessary. And this could include the transversus abdominis release, or TAR, as I'll refer to it from here on out. The steps of this procedure are shown in the top picture. And currently the use of this additional procedure is decided intraoperatively at the surgeon's discretion. To help with this decision, the rectus to defect ratio, or RDR, was created as a tool for preoperative planning and only requires a single pre-op CT, and from which you get 3 measurements: left rectus width, right rectus width, and width of the hernia defect. This tool has been extensively discussed in a prior paper and proven to work in open midline ventral hernia repairs with an RDR greater than 2, indicating that additional myofascial release will be necessary in less than 10% of cases to achieve full fascial closure. So the objective of this study was to determine if RDR is also effective in robotic, extended, totally extraperitoneal, or ETEP procedures, given the need for pneumoinsufflation. So to do this, we identified patients from the prospectively maintained Abdominal Core Health Quality Collaborative and patients who underwent ETEP at Prisma Health. And patients were excluded if they did not have imaging within a year of surgery, if they had defects that were non-midline, or if they were repaired with the double dock technique. Data points gathered include patient demographics, comorbidities, type of release performed, and ability to achieve fascial closure, and the dimensions of the hernia and abdominal compartments. So these measurements were conducted within the imaging platform at the widest width of the hernia defect. As you can see in the CT scans, the image on the left has much larger rectus muscles compared to the defect size, corresponding to a much higher RDR. Then this ratio is especially helpful in less obvious cases. If you were to just eyeball these two, you might think that the hernia on the left is more difficult to repair given the bigger sac, but the rectus muscles there are larger, and if you calculated RDR, you'll find it to be 2, whereas the RDR on the left is 1. Consequently, the patient on the left did not need TAR, whereas the patient on the right did. So here's a breakdown of our patient population. There were 188 patients total, with comorbidities representative of the larger patient population. And so mean hernia width was 6.3 for the group without TAR and 11.0 for the group that needed TAR. And average RDR was 3.5 for the group that did not need TAR, and smaller at 2.2 for the group that required TAR. We did perform receiver operated curve analysis to find the highest area under the curve, which was 2.6. But this measurement is less important. This precise 2.6 is less important than this spectrum that we get with analysis of a RDR greater than 2 will require fascial closure without the use of tar in 12.2% of cases. Okay, so the limitations of this study include slight inter-rater differences in measuring the abdominal compartments and a smaller sample size, which we would address by expanding this study to a larger population. And so this tool can be more validated and generalizable with the end goal of the surgeon being able to determine 1, if tar is likely to be needed, and 2, allow the surgeon to be confident that they can perform a tar if it is needed. Additionally, there's hope of combining this with preoperative ultrasound elastography to help determine abdominal wall compliance, because RDR is a great and simple tool for determining the likelihood of tar, but it's not great at determining the abdominal wall compliance itself. So in conclusion, as in open ventral hernia repairs, RDR is still a simple and effective tool for predicting tar in robotic repairs. Thank you.
Our invited discussant is Dr. Ann Mancino.
Hello, very nice presentation. It's known that primary fascial closure over reinforced mesh does actually result in lesser complications and recurrence rates. And myofascial release procedures have been used to allow this midline fascial closure. Preoperative assessment of the ability to achieve this fascial closure can allow for better patient counseling, as you said, and also for preparation for the surgeon who may not always do these release procedures. The authors have previously developed a radiologic-based metric that was able to predict the probability of needing additional myofascial release to achieve fascial closure and open repair, and now have confirmed that this metric is also predictive in the need for transversus abdominis release and robot repair. And congratulations, because I think this will be very helpful in some surgeons when they're planning their robotic repairs, which are becoming consistently more prevalent. I do have a couple of questions about some of the data, which this was from the paper. I noticed that some of this was not presented in the talk, but I think you obviously you know it from your paper. So one was that not only were the RDR and the width of the defect significantly different between the TAR group and the non-TAR group, but also the length of the hernia defect was significantly different in the group. And I just wondered if you had ever evaluated adding this length, because then that's obviously the total area of the defect, to this predictive metric and see if it helps make it even more predictive. And the other question was that in your demographic data, which you didn't include here, it was interesting that your average BMI was 36, which is not totally surprising in people with hernias. But there were actually significantly lower BMI in the patients that ended up needing TAR. I think that was like 31. And so I was just wondering if you had any thoughts on why these people who actually had a lower BMI ended up needing the release. Thank you.
Thank you. Thank you for these questions. So with the length, I am not sure, but I could assume that it is because they're trying to estimate, I guess, the ability of the wall to fully close over top of the defect in a horizontal manner. But I don't know, given I've never done a hernia repair before, I'm not sure why that would be. But then with the BMIs, in our discussion, we were talking about how patients who need TAR often are the ones that have the smaller abdominal muscles that have atrophied over time because of chronic disease. So that could possibly be a case. They're the sicker patients that are more I would say Yeah.
To your point about obese patients, smaller, that's part of what is beautiful and important about this to us, I think, is because, classical dogma dictates big person, big hernia, probably gonna need a TAR, but in actuality, when you look at those people on CT, a lot of times there's a big donut of subcutaneous space, and a tiny little person trapped down in there. And so they've got this big hernia, but they actually have tiny little atrophy rectus muscles, and so that ends up necessitating you needing to do a TAR just because you can't stretch what is there without some extra help. With regards to the vertical aspect, these were near exclusively top-down VTEPs, and so from that vantage point, it didn't really add tension. If you had to go xiphoid or pubis, more about the lateralizing of these. So that again, kind of classical dogma says hernia defect area should help you, but that doesn't relativize it. That's not a word, but we just made it one to the size of the patient. And so really, this was more of an effort to say, if Andre the Giant has a 5-centimeter hernia, that's probably not a very big hernia, but it might be a really big hernia on future Dr. Davis. So that was just more of an effort to try to get our eyes to look at what matters and not necessarily what doesn't, because we've all been sort of conditioned so long ago. That's this wide and it's this long, and it's probably going to be hard. And I think the second set of images she put up there really nicely displayed, like, it's not all about just kind of your initial reaction when you look at how big that thing is. It's really important to consider relative size of the hernia, relative size of the patient. At the end of the day, it's really an effort to estimate abdominal wall compliance. So occasionally it'll still fail you because you don't truly know that compliance till you get in there, start pulling on them, and realize that these are atrophy, they're not going to move. But it'll help you keep your foot out of your mouth more often than not.
Thank you.
Thank you.
Thank you so much. Andrew Wong from Cedars-Sinai. That was a beautiful presentation and a really good patient cohort that you guys had. I had basically just some technical questions. You partially answered one. You're doing a top-down ETEP. And so my other question is, are you doing unilateral TAR or bilateral TAR? Is your grading system, does that also encompass whether you need to do both sides or just one side? Vast majority of patients did get a bilateral TAR. There were a couple unilaterals. We have that data sequestered. We haven't really decided how to utilize that or if it matters if you got one versus the other, because I think more the goal is trying to help out people who are having decision points that are, all right, I want to do an ETEP, but I don't want to do an ETEP TAR. So I think if I have to do a TAR, I'm going to do this open. Or people who say, I can do a Reef Stopa open, but if a TAR brings into the equation at all, I'm not touching it. And so it's more aimed at trying to help that decision point up front. So even a unilateral TAR is a TAR, and that would put, the people we just kind of hypothetically brought up off that patient. Got it. Thank you so much.
Don't go away because I have a question you might ask. Hi, Stephanie Neer from Texas Tech, El Paso. My question, and you're welcome to answer it if you can, but otherwise I'll let him do it, was you showed that one patient who had a large component of a very large hernia outside of the abdominal cavity. And so someone who we might be concerned about loss of domain affecting that. And I wondered whether your model takes that into account at all.
That is a very good question that we are keenly interested in answering. We have a secondary metric called accommodating volume based on doing pre-op pneumoperitoneum for patients that were worried about loss of domain. And that's one of our areas of interest, is trying to combine all of this into one more master metric and like sort of piggybacking off of the work of Tanaka with the Tanaka score and all that. So this was more of kind of a simple metric of, hey, did the window dressings cover the window? But to your point, once you start getting a huge sac like that, now you've got to worry about, do all your viscera fit back in that cavity that's not necessarily big enough for it now? That's a slightly different question, but if there's a way to combine those answers, we're just still working on how to make that clean at the moment.
I look forward to seeing.
Thank you.
Last paper of the session is outcomes of subsequent abdominal operations after ventral hernia repair, being presented by Anna Hayden from the University of South Carolina School of Medicine. And this is also a Lowry Award finalist paper.
Hi, everyone. My name's Anna Hayden. I'm a third-year medical student at the University of South Carolina School of Medicine in Greenville, which is affiliated with Prisma Health Hospital System. Thank you to Southwestern Surgical Conference for the privilege of presenting our work. Here are our disclosures. I have no disclosures. So the number of ventral hernia repairs performed annually is increasing, with over 600,000 repairs performed annually. A significant number of these patients will ultimately require a subsequent abdominal operation. A VA study indicated over 25% of patients required a subsequent abdominal operation after an initial ventral hernia repair. From this point on, I'll refer to subsequent abdominal operation as SAO. An SAO was needed in 17% of 2 other studies, including evaluation of laparoscopic repairs performed at our institution. SAOs potentially increase the risk of enterotomy, bowel resection, difficult adhesiolysis, conversion from laparoscopic to open procedure, secondary mesh infection, as well as hernia recurrence. There is significant heterogeneity in surgical approach and technique, mesh selection, and mesh position. Mesh position in particular potentially impacts the risk of complications. One study of intraperitoneal mesh required bowel resection during SAO in 21% of cases when intraperitoneal mesh was present. Another found similar rates of enterotomy or unplanned resection. This potential source of contamination is a particular concern for secondary mesh infection. Reviewing our experience with mesh infection, nearly 60% involved intraperitoneal mesh and 38% developed only after an SAO. So the hernia repair that you do today does in fact impact future abdominal operations. So our study aims to compare both the incidence of SAO after ventral hernia repair with intraperitoneal versus extraperitoneal mesh and compare both operative and postoperative outcomes. We respectively reviewed all ventral hernia repairs with mesh performed from 2006 to 2020 at Prisma Health Upstate. This included open, laparoscopic, and robotic repairs. Chart review was performed to capture incidents of, details of hernia repairs, and the subsequent operation. We excluded patients with inguinal hernias, non-mesh repair, atypical hernias, and significant meshing data. So we had a total of 2,626 patients. 35% had intraperitoneal and 63% extraperitoneal mesh. SAO was required in 462 patients, significantly more frequently after prior IPM compared with EPM. Comparison of SAO in patients with prior IPM versus EPM showed no significant differences in demographic or comorbidities. The total number of SAOs was similar between groups, though patients with prior IPM had a longer interval between hernia repair and SAO. For early SAO, more patients required mesh removal after IPM placement, with 16.6% requiring early explantation. For late SAO, hernia recurrence or hernia at a new site was the most common indication, and hernia recurrence was significantly more likely after intraperitoneal mesh. Overall, cholecystectomy was the most common other reason for SAO. SAOs were more likely to be performed laparoscopically with IPM. Cases were clean in fewer than 50% of cases, which poses the greatest risk of secondary mesh infection, particularly with intraperitoneal mesh. This risk of secondary mesh infection was the dominant factor in the greater number of IPM removed at the time of SAO. 25% of cases included removal of SAO compared with just 15% of extraperitoneal mesh. Interestingly, we were not able to identify any difference in documented difficulty of adhesiolysis between groups. However, a significant number were not documented, and without standardized grading scale, interpretation during our chart review was difficult. More objective measures of difficult adhesiolysis, such as conversion from MIS to open or a documented difficult abdominal cavity entry, were no different. Postoperative outcomes for IPM and EPM were no different after SAO. Two significant trends were seen, however. The rate of secondary mesh infection for IPM was nearly triple that of EPM at 3.4 versus 1.2%. This is notable in particular because our practice has evolved to remove IPM in most cases of SAO, particularly in non-clean cases. This rate, 3.4%, would likely be higher otherwise. Hernia recurrence is also higher after SAO with IPM, most likely due to the higher rate of mesh explantation required. In summary, SAO is a common requirement after ventral hernia repair, occurring in at least 17% of patients for a variety of hernia and non-hernia related intra-abdominal pathology. SAO is required more commonly after intraperitoneal repair. Contrary to our expectations, adhesions and adhesion-related complications such as enterotomy or conversion to open were not more frequent with IPM compared to EPM. However, we did find nearly a 3-fold higher rate of secondary mesh infection from subsequent abdominal operation with IPM, and this despite this significantly higher rate of mesh explantation. For this reason, we advocate removal of prior intraperitoneal mesh during open SAO, especially for non-clean cases. Thank you for your attention. I'd also like to thank Prisma Health and University of South Carolina. I'm happy to take any questions.
Dr. Cryer from the University of Hawaii apologizes for not being able to be here in person to discuss this paper, but I have his comments right here. Thank you for this opportunity to discuss this paper, and I apologize for my physical absence. I'm very much enjoyed reviewing the research of Ms. Hayden et al. In their paper entitled Outcomes of Subsequent Abdominal Operation After an Initial Ventral Hernia Repair. This paper is a 15-year respective review of a single center institution / health system experience with ventral hernia repair, encompassing all approaches with the primary outcome of complexity and complications of subsequent abdominal operations relative to mesh position, intraperitoneal versus extraperitoneal in the abdominal wall. They conclude that the incidence of subsequent abdominal operations is higher with intraperitoneal mesh, but surgical outcomes are similar. However, due to the risk of secondary mesh infection with intraperitoneal mesh, significantly more of these were removed at the time of subsequent abdominal operation. First, I applaud this review in its scope and goals. Part of our collective improvement in ventral hernia repair over the past 30 years has been due to the comprehensive and focused review of individuals, institution, and systemic practices with hernia repair. And this paper furthers our understanding and knowledge regarding optimal treatment and common problems. This paper will help serve the surgical community and our patients going forward as it pertains to the ideal treatment of ventral hernias. Second, I hope this will lead to further studies, perhaps someday culminating in a larger prospective multi-institutional review of mesh position, mesh selection approach, and management of hernia patients undergoing subsequent abdominal operations to help us definitively answer some of these questions. Finally, I do have some questions regarding their conclusions. One, the author states the rate of secondary mesh infections was almost 3-fold higher with intraperitoneal mesh, but this did not reach statistical significance. This likely reflects the evolution of our practice in routinely removing intraperitoneal mesh during subsequent abdominal operations for recurrent ventral hernias or in the setting of any degree of contamination. It'd be helpful to know if there are any other factors that motivate you to evolve your practice to routinely remove intraperitoneal mesh, or if it's solely the higher rate of secondary mesh infections, as this result is a higher rate of hernia recurrence with recommendations. What recommendations do you have, either based on the study, current practice, or how you manage these patients for higher recurrence rate? The second question is, while the outcomes of intraperitoneal mesh versus extraperitoneal mesh were discussed, it'd be helpful to know more demographic and operative data on the groups. That is, were they similarly matched for comorbidity standpoint, obesity, diabetes, smoking status, and operative standpoint, hernia size, primary incisional fixation overlap? This would potentially allow other factors to be excluded or excluded in the subgroup analysis. I can't help but wonder if the higher rate of subsequent secondary mesh infections could be somewhat attributed to comorbidities. I also wonder if there's a decision to place mesh in the extraperitoneal position was dictated by an increasing use of robotic approach or complexity with the index hernia repair based on the indications of a more complex abdominal construction. Most of the current European Hernia Society and American Hernia Society ventral hernia repair guidelines based on evidence and consensus voting, weakly recommend the use of permanent mesh placed in the extraperitoneal space for open ventral hernia. Minimally invasive approaches, especially when the risk of infection is increased, and overall a tailored approach based on the patient and their hernia size. These recommendations make sense from what we currently know, and this paper helps to reinforce and further those conclusions, as well as address the very real fact that many of these patients will require a subsequent abdominal operation. Perhaps the extraperitoneal position will be more strongly recommended and widely adopted in the future.
So I've got a slide for his second question that's on the end. But for the first question, so Prisma Health has largely evolved to remove intraperitoneal mesh during a subsequent abdominal operation due to the experience of the practice in the management of mesh infections. As mentioned prior, we found that nearly 40% of all of our cases of mesh infection were developed secondarily after an SAO. Infected mesh in the intraperitoneal position is rarely salvageable, and it's reflected in the 25% rate of removal found in this study. And the series is limited only to patients initially repaired at our institution, Prisma Health, while the review of mesh infection included both of our own and patients initially repaired elsewhere. As far as his second question regarding demographic and operative data for the groups, we have that here. We chose to focus our manuscript more on surgical outcomes. We didn't find any significant differences in patient comorbidities or hernia width. Distribution of hernia type was also somewhat different, with incisional hernias representing 74% of EPM cases and 89% of IPM cases. However, since secondary mesh infections occur due to the SAO, not the index ventral hernia repair, it's not clear what impact the initial hernia type would have had on the risk of infection after SAO. Mesh selection clearly differs between IPM and EPM. IPM requires barrier-coated mesh, and EPM is almost entirely largely poor monofilament mesh, which is more easily salvaged. So it's difficult to compare mesh type between IPM and EPM. As uncoated mesh is discouraged for IPM and coated mesh is discouraged for EPM. The decision to place mesh extraperitoneal is not dictated by the use of the robotic approach. Rather, the robotic approach facilitates minimally invasive placement of extraperitoneal mesh, which was already our preference. Certainly for larger or more complex hernias that require an open approach, EPM is the preferred type of mesh. Most of our patients formerly repaired laparoscopically with intraperitoneal mesh, obese, diabetic, et cetera. Those with higher risk of a surgical site infection have transitioned to robotic retromuscular repair.
Great. Are there any other questions from the audience? And looks like we're finishing right on time. Thanks, Hannah. Great presentation.
All right. We're going to be looking forward to the